Which of the following is a part of WHO guideline for the management of second stage of labor? Option A, do a routine episiotomy, manual support to perineum to maintain flexion of the head, never give warm compression to the perineum. Now, option number D is perform labor in lithotomy position. The practice of guarding the perineum during delivery of the fetal head is a part of WHO management guideline for the second stage of labor. The finger of one hand support the perineum while the second hand applies pressure to the fetal head to control the speed of crowning. The advantage of this is to prevent the perineal tears. The labor begins with second stage of the labor begins with full dilation of the cervix and ends with the delivery of the fetus. The main events include the descent of the fetus, bearing down by the mother, uterine contractions, cardinal movements of labor and delivery of fetus. Second stage for nulliparous and multiparous. Second stage, mean and average duration. For nulliparous it is 50 minutes, for multiparous it is 30 minutes. Maximum duration. Second stage maximum duration is nulliparous is 2 hours plus 1 with epidural. For multiparous it is 1 hour plus with epidural. WHO maximum duration of second stage or diagnosis of arrest is 3 hours, and for multiparous it is 2 hours. Management of second stage of labor. The most common position used in the dorsal position with the hip flexed, knees flexed and abduction of the thighs. WHO recommends any position of choice including upright position. The most common position used in the is the dorsal position with the hip flexed, knees flexed and abduction of the thighs. WHO recommends any position of choice including upright position. WHO recommendations for the prevention of perineal tear include warm compression to the perineum, perineal massage, guarding the perineum and modified Ritgen's maneuver. Modified Ritgen's maneuver, a sterile towel or pad, Modified Ritgen's maneuver is a sterile towel or pad is held in one hand and placed over the perineum, whereas the other hand applies gentle downward pressure on the occiput to promote flexion and control delivery of head, ensuring the smallest diameter of the head passes through the outlet. Once the occiput is borne with gentle pressure, the head is extended. Extended for forehead, nose and mouth are then delivered. WHO doesn't recommend fundal pressure. WHO doesn't recommend fundal pressure and routine episiotomy. Other options like option A liberal or routine episiotomy is discouraged. Episiotomy is indicated in cases of shoulder dystocia, breech delivery, fetal macrosomia, operative vaginal deliveries, persistent occiput posterior position. Option C is manual techniques. Manual techniques such as massage or application of warm compresses are recommended for healthy pregnant women requesting pain relief during labor. Option D is the position that is most comfortable to the mother is upright. Squatting position is encouraged. This position gives less discomfort and difficulty in bearing down, less labor pain, less perineal or vaginal traumas and wound infection. Third question is identify the best parameter to assess in case of male infertility. Option A is quantity of sperms, option B is the motility of the sperms, option C is Morphology of the sperm, option D is number of sperms. The most important is the morphology of the sperms. The morphology of sperms is the best parameter to assess the male infertility. Characterization of normal sperm morphology shows improved correlation with fertilization rate during IVF cycles. The criteria requires careful analysis of the following: the shape and size of the sperm head. The shape and size of the sperm head. Second is the relative size of the acrosome in proportion to the head. Three is characteristics of tail including length, coiling or presence of two tails. Significant decreased fertilization rates are observed when normal morphology of the sample falls below 4%. Abnormal sperm morphology is termed teratospermia or teratozoospermia, whereas sperm concentration and progressive motility have been distinguishing fertile from infertile man. Strict sperm morphology as determined by an individual having extensive training and experience was the most discriminating value. Parameters in sperm analysis and reference limits. The volume is the volume of reference limit, like volume of semen analysis is more than equal to 1.5 milliliter and count is more than equal to 15 million per ml. Total motility is more than equal to 40%. Morphology is more than equal to 4%, and normal forms WBCs is less than 1 million per ml and round cells is less than 5 million per ml. Question number 4 is: a 26-year-old woman underwent a workup for primary infertility. On hysterosalpingography, there was a bilateral cornual block. What is the next step in the management? Option number A is tubuloplasty. Option number B is hysteroscopy and laparoscopic guided surgery. Option C is hydrotubation. Option D is in vitro fertilization. Okay, in the given clinical case scenario, the next step of management will be hysteroscopy and laparoscopic guided surgeries. Tubal contraction, particularly cornual spasms, can give an incorrect impression of proximal fallopian tube obstruction, a false positive result on hysterosalpingography. Laparoscopic with chromotubation is therefore considered to confirm the diagnosis of cornual spasm. Laparoscopy is both diagnostic and therapeutic in this condition. Hysteroscopy is an operative procedure that provides an endoscopic view of endometrial cavity and tubal ostia via the cervix, performed in pre-ovulatory phase. It can be diagnostic or it can be therapeutic. It is the gold standard investigation for visualizing the uterine cavity and tubal ostia. Therapeutic indication of hysteroscopy. What are the therapeutic indication of hysteroscopy are uterine septum, Asherman syndrome, retained IUCDs, polypectomy, submucous fibroid, abnormal uterine bleeding, tubal sterilization using sclerosing agents, and diagnostic indication of hysteroscopy are to study the endocervical mucosal lining and congenital malformation of uterus, endometrial tuberculosis, misplaced IUCDs, endometrial lesion, endometrial polyp, Asherman syndrome, cornual tubal blockage. Contraindication to hysteroscopy are as follows: acute genital tract infection, for example genital herpes infection, Viable intrauterine pregnancy. During menstruation in the view of obscured, the infection rate is high. Scarred uterus and enlarged uterus of size more than equal to 12 weeks are relatively contraindication. Cervical stenosis can cause cervical tear and uterine perforation. Cardiopulmonary disorder due to increased risk of fluid overload and pulmonary edema. Known case of cervical cancer. Laparoscopy is the gold standard for the evaluation of tubal factors in infertility. Commonly done in commonly done in proliferative phase. It can be diagnostic and therapeutic. Diagnostic is age more than 35 years, history of pelvic pain, dyspareunia, pelvic surgery, adhesions, abnormal HSG, failure to conceive after reasonable period for 6 months with normal HSG, women with comorbid pelvic pathology, PID, endometriosis, and therapeutic are operative, such as unexplained infertility, reconstructive tubal surgery, adhesiolysis, fulguration of endometriotic implants, ovarian drilling in PCOS, gift and ZIFT procedures. Benefit of laparoscopic evaluation. Tubes for detection of tubal patency, block site and side, motility, hydrosalpinx, changes, periotubal additions, fimbriae agglutination, ovaries like PCOS changes, endometriosis, PID additions, uterus anomalies, fibroids, peritoneal factors like adhesion, PIDs, endometriosis, tuberculosis, therapy at the same sitting as appropriate. What are the management of female infertility for different cause are as follows. Etiology, for example, there are etiology investigation and management. For etiology of tubal causes, female infertility, the investigations can be hysterosalpingography or sonosalpingography. Second is phalloscopy. Third is salpingography. Fourth is laparoscopic chromoperturbation. And these are all investigation. Tubal cause, the management is laparoscopic adhesiolysis. Okay. Second is tuboplasty. Third is hysteroscopic cannulation and ballonoplasty. Third is hysteroscopic cannulation and ballonoplasty. And fourth is if all the procedures fail or not feasible, go for IVF or gift. And previously it was a tubal causes, and now it is a ovarian related. Ovulation monitoring by ultrasound like BPT and BPI and endometrial biopsy for tuberculosis is done. If the above steps are abnormal, do a hormonal study. Okay, investigation if FSH, LH and prolactin, E2, P level, thyroid and diabetes. And management. What are the management if there is a ovulation related in female infertility? Clomiphene and letrozole. If it fails, give FSH, LH and GnRH. Check for a response. If there is no response, do IVF donor egg. Fourth is if all above measure fails, the final option is to adopt. Other cause, if there are other cause, go for ultrasound, MRI, SSG, hysteroscopy and treat the cause. Okay. Fifth question is a 40-year-old woman comes with history of postcoital bleed and a visible mass seen in the cervix per speculum. What is the next step to be done? Option number A is conization. Option number B is cryotherapy. Option number C is targeted biopsy. Option number D is pap smear. A targeted biopsy is the next line of management in the patient with visible cervical mass and postcoital bleed. A pap smear is done only when there is symptoms with no identifiable lesion. Okay, targeted biopsy is the next line of management in the patient with visible cervical mass and postcoital bleed. A pap smear is done when there is a symptom with no identifiable lesion. Other options, for example, like option number A is conization. Conization is an invasive process where the cervix is cut in a cone shape manner. It is both diagnostic and therapeutic. It is indicated for diagnosis in women with HSIL or adenocarcinoma in situ and may be considered under the following conditions. The limit of lesions cannot be visualized with colposcopy. Okay, the limits of lesion cannot be visualized with colposcopy. SCJ or squamous columnar junction is not seen in colposcopy. Option number 3 means there are colposcopy is positive in CIN2 and CIN